Hello, everyone, and welcome to our module on opioids. Before we talk about opioids, let's talk about endorphins. Endorphins are naturally occurring substances. They are produced inside our body, and they are peptides that can activate the opioid receptors found in our body. Endorphins are divided into three families. First are the endorphins, second is the enkephalins, and last is the dynorphins. And endorphins are large peptide molecules. For example, this is the structure of dynorphin A on the left here, and this is the structure of beta endorphin on the right here. So endorphins are the naturally occurring substances that activate opioid receptors. You can find opioid receptors on neurons in the central and peripheral nervous system. And there are three key subtypes of opioid receptors: the mu receptors, the delta receptors, and the kappa receptors. And a different family of endorphins works on each receptor type. So the endorphins have the highest affinity for the mu receptor, the enkephalins have the highest affinity for the delta receptor, and the dynorphins have the highest affinity for the kappa receptor. For the Step 1 exam, they will expect you to know how opioids and opioid receptors exert their effects on nerves, so let's talk about that now. First of all, opioid receptors are coupled to G proteins, and when they are activated, they can have effects on the presynaptic and the postsynaptic neurons. On the presynaptic neurons, they close calcium channels, and this reduces neurotransmitter release. I'll show you a picture of this in a minute. On the postsynaptic neuron, they open potassium channels. This leads to hyperpolarization and makes it harder for signals to be transmitted. So via these effects, there's decreased activity of neurotransmitters in the nervous system when opioid receptors are activated. In particular, glutamate, an excitatory neurotransmitter, glutamate activity is reduced. There's also evidence of less release of neurotransmitters like acetylcholine, norepinephrine, serotonin, and substance P. Here's my own drawing of a synapse in the nervous system. We have a presynaptic neuron and a postsynaptic neuron. In order for a neurotransmitter to be released and a signal to be transmitted, calcium has to enter the presynaptic neuron. In addition, the postsynaptic neuron is polarized because potassium is leaving through potassium channels. So what happens when opioid receptors are activated is that calcium entry into the presynaptic neuron is inhibited. This leads to less neurotransmitter release. In addition, potassium channels are activated so that the postsynaptic neuron becomes more negatively charged. In other words, it becomes hyperpolarized. This means that even if neurotransmitter is released, it's harder to depolarize the postsynaptic neuron. So for both of these reasons, you have decreased nerve transmission, and that's why opioids and the activation of opioid receptors suppresses nervous system activity. The reason we're talking about opioids in the substance abuse section is because there are a number of drugs which activate opioid receptors, and these drugs often become drugs of abuse. The prototype opioid drug is morphine. This is its chemical structure on the screen here, but there are many other so-called opioid drugs that activate the opioid receptors. These include hydromorphone, piperidine, fentanyl, codeine, and many, many others. Now, morphine and all these opioid drugs have medicinal uses. However, heroin has no medicinal uses. It is only a drug of abuse. Heroin's chemical name is diamorphine, and you can see on the screen here that it has a structure that is very similar to morphine. Let's talk briefly about the metabolism of opioid drugs because this is high yield for Step 1. The drug they're going to want you to know about is morphine. Morphine undergoes conjugation in the liver where it's combined with glucuronic acid, and it can form one of two molecules, either morphine 6-glucuronide or morphine 3-glucuronide. Now M3G is inactive, however M6G is an active analgesic with properties similar to morphine. It's eventually excreted by the kidneys, but in patients who have renal failure, one of the reasons they can develop toxicity from morphine is not from the morphine itself, but from the M6G metabolite, which is renally excreted. The way heroin is usually abused is by injecting it into a vein, and you should be aware that in addition to the opioid effects, many patients have adverse effects from heroin abuse because they use dirty needles or they inject contaminated drugs into their bloodstream. So for example, many IV drug abusers develop bacteremia, and this can cause endocarditis classically on the tricuspid valve because the venous blood flow goes right into the right heart and the bacteria land on the tricuspid valve. Patients who use IV heroin are also at risk for hepatitis B and C and HIV, and this is all because of the use of dirty needles or contaminated heroin drugs. The reason that people abuse opioid drugs is because they make people feel good. So let's talk about those effects now. In terms of the central nervous system, most of the effects are mediated through the mu receptor. These effects include pain relief and analgesia, also euphoria, and also sedation. And so people feel good when they take these drugs, and that's why they become drugs of abuse. Other central nervous system effects include respiratory depression. If someone overdoses on opioids, the reason they will die is because they will stop breathing. Opioids also suppress cough via the central nervous system, and that's why codeine is sometimes used as a cough suppressant. Opioids also cause the pupils to shrink. This is called meiosis. And for this reason, if you see someone with acute opioid intoxication, they will always have pinpoint pupils. The one exception is meperidine, which is also called Demerol. It does not have the pupil effects. That's the only opioid drug for which this is true. In the peripheral nervous system, the two main effects of opioids you should know about are constipation. This is through effect on nerve cells in the GI tract, and also skin warmth and flushing. If you meet patients who chronically take opioids, one of their main complaints will be that they are constipated. So like I told you before, even though opioids are drugs of abuse, they also have many clinical uses. The main one is pain control. In addition, IV morphine is very effective in acute pulmonary edema. One of the main problems with pulmonary edema is that patients become terrified from the feeling that they can't breathe. Morphine relieves this feeling, so even though it doesn't do anything for the pulmonary edema, it helps patients to feel better, and this is something that's very useful at the bedside when a patient is in respiratory distress. Codeine, as I told you before, is often used as a cough suppressant. Loperamide activates opioid receptors in the GI tract, and it can be used to treat diarrhea. And then finally, patients who are shivering, especially from an infection or side effects of some antibody chemotherapy agents, these patients are often given meperidine, which is called Demerol. And remember what I told you before, opioids cause skin flushing and warmth, and it often makes the shivering better. When you prescribe opioids for pain control or some other legitimate medical indication, you have to be careful because these drugs are highly addictive, and many patients with a substance abuse disorder related to opioids began their problem when they were prescribed drugs by a doctor for a legitimate reason. You should also know that patients who use opioids chronically, whether for a legitimate reason or as a drug of abuse, these patients develop what's known as tolerance. This means that the drugs have less effect over time and higher dosages are required to achieve the effects. The exceptions to this are meiosis and constipation. These persist even when patients are tolerant to opioids. So if you see a chronic opioid user in the emergency room, even though they may have less pain effects from the drugs, they will still have meiosis and constipation because there is no tolerance to these two opioid effects. When you work in the emergency room, patients will often come in wasted on opioids, and in many cases, they won't be able to tell you what drug they took. So you need to be able to recognize acute opioid intoxication. First of all, you should be aware that opioids are dangerous. They are the most common cause of drug-related overdose death in the United States. Patients who are acutely intoxicated will have mental status changes. This can range from euphoria to a depressed mental status and even unresponsiveness. As I told you before, their respiratory rate will be decreased. They will also have decreased bowel sounds. And when you examine the eye, the pupils will be constricted or myotic. In rare cases, opioids can even cause seizures. This most commonly occurs with two specific opioids, tramadol and meperidine. The treatment for a patient who is acutely intoxicated with opioids is naloxone. It goes by its trade name Narcan. It's a short-acting opioid antagonist. Its structure is shown on the screen here. You can see that it looks a lot like morphine, and therefore it blocks opioid receptors. Now, when you administer this drug, this can cause withdrawal if the dose is too high. This is called overshooting. So when you administer naloxone, patients will acutely reverse all of their effects. Their mental status will improve, their respiratory rate will pick up, but sometimes they will go past that stage and develop symptoms of withdrawal. So that's a nice segue into opioid withdrawal. There are basically two ways you can get symptoms of opioid withdrawal. The first way is if all your opioid receptors are occupied and you suddenly give an antagonist like naloxone and knock the opioid agonist out of the receptors, that can cause withdrawal. The other way is that if you have an opioid-dependent individual who stops taking the drugs about 6 to 12 hours later, that patient will start to develop opioid withdrawal. An easy way to remember the symptoms of opioid withdrawal is to just understand that they represent a reversal of all the usual opioid effects on the central nervous system and other organs. So first of all, opioids normally depress the central nervous system. Opioid withdrawal therefore causes the opposite effect, and that is restlessness. Three very unusual effects that go together in opioid withdrawal are yawning, rhinorrhea and lacrimation, and piloerection. If you ever see these three things described in a board question, you should immediately think of opioid withdrawal. Yawning is just a peculiar effect of opioid withdrawal. Rhinorrhea and lacrimation happen because the eye effects are reversed and the eye begins to water, and that water travels to the nose, and this causes rhinorrhea and lacrimation. The piloerection is a reversal of the skin effects, so the hair on the skin will stand up. And then finally, when the GI effects reverse, the GI tract begins moving, and that could cause nausea, vomiting, abdominal cramps, and also diarrhea. For patients with opioid use disorders, there are a couple of medications that can be taken daily in order to reduce the risk of a relapse. So let's talk about those now. The first one is buprenorphine. This is the structure of buprenorphine at the bottom right side of the screen here. It has features that resemble other opioids like heroin or morphine, and for that reason, it functions as a partial agonist of opioid receptors. Partial agonists are drugs that have some agonist and some antagonist effects. And the idea here is that buprenorphine has some agonist properties at opioid receptors, but not as much as full agonists like heroin or morphine. For that reason, this drug will partially activate the opioid receptors, and that's what can reduce the cravings and the risk of relapse among people with opioid use disorders. Buprenorphine has a long duration of action. It is slowly absorbed when administered as a sublingual tablet under the tongue. And there are a couple of special features of buprenorphine that you need to be aware of. The first one is this drug is not regulated or controlled in the same way as methadone, which we'll talk about in a minute. Buprenorphine is what's known as a Schedule III controlled substance, and that means that it can be administered by a provider giving a written prescription in the office. This is different from methadone, which is much more tightly controlled. Second thing to know is that buprenorphine does have antagonist effects, so it can cause withdrawal, like naloxone, if you administer it to someone who is acutely intoxicated. And then finally, you need to be aware that buprenorphine is always given as a combination tablet together with naloxone. So why is naloxone mixed into the tablet? This is done to prevent abuse. Naloxone is not absorbed when the tablet is taken appropriately under the tongue. However, if a patient attempts to crush the pill and inject it intravenously in order to get a high, there will be no effect. And that's because naloxone is present in the tablet and it will block any opioid effects of buprenorphine. Methadone is another medication that can be given to patients who have opioid use disorders in order to limit the likelihood of a relapse. It is a long-acting oral opiate, and it reduces the cravings among people who have an addiction to either heroin or to morphine or some other opioid. It's given as what's known as maintenance therapy, so patients take it every day in order to limit the cravings and make it less likely that they will relapse. Importantly, however, methadone is strictly regulated and controlled. It's highly addictive, and it is a Schedule II controlled substance. Schedule II controlled substances are the most tightly regulated substances that can be prescribed, and for this reason, patients usually have to go to a special methadone clinic in order to receive this medication. That is different from buprenorphine, which we talked about in the last slide, which is a Schedule III controlled substance. The last drug that can be used to help addicts stay clean is naltrexone. This is a long-acting opioid antagonist, and it blocks the effects of opioids if taken. This is administered to detoxified patients to prevent relapse. The idea here is that patients who were heroin abusers, the way that they often relapse is they have a particularly bad day and they shoot up once, and then they get high and it feels so good that they go back on heroin. If they're taking naltrexone every day, then if they have a bad day and they shoot up, they won't get any high from the drug, and this can prevent relapse. There are data showing that naltrexone prevents relapse, and that's why it's used in patients who are opioid or heroin addicts. You should know that this drug is also used in alcohol abuse, and I talk about that in another video. And that concludes our module on opioids.